Hello, everybody, and welcome back to the Neurotransmitters. We're very glad to have you with us again today as we continue our chief concerns. We are your co-hosts for this. I am Dr. Michael Kentris, and I am joined again today by the inimitable Dr. Galina Geichman. Galina, how are you today?
Hi, Michael. Thanks so much for having me back. I am loving this series and so excited to co-host yet another one with you. And I'm especially excited this morning to welcome a friend and mentor and colleague, Dr. Seth Gale, to talk with us about the topic of cognitive change. Dr. Gale is co-director of the Brain Health Program at the Mass General Brigham and one of the leaders in our division of cognitive and behavioral neurology. And he spends a lot of his time working with patients with various cognitive changes, as well as leading our Alzheimer's treatment program and several clinical trials and some other fun things on the side that maybe we'll get to as well. Welcome, Seth.
Thank you so much for having me. It's a pleasure to be here. I look forward to taking your lead, Galina, on getting some information out there to everybody.
Well, I'm really excited for today's session in particular because I remember that over the course of my own training as a resident, what we did for patients with cognitive change has changed, right? So I think in the past, we were kind of like, oh, okay, yeah, it's okay if you have a memory complaint. We have time to figure this out. And with the ability to potentially make treatment available to patients, I think all of us have that kind of, higher level of, sense of a threshold to make a diagnosis, to gain understanding what's going on. So let's just start really taking a step back and think about, you being in the cognitive clinic, what are the most common referrals that you get and how do patients get to you if they're being seen by someone else who thinks they should be seen by someone who's a cognitive specialist?
That's a great question. It really varies, right? So in our setup, most of the referrals are internal from our health system. So it's often from primary care. There will also be general neurologists and psychiatrists who will refer on to cognitive and behavioral neurology. I mean, it is like everything in our medical world. It's really subspecialized, and so there's a variety, but that's usually the referral pattern. And I'd say there's a couple of particular patient and family reports that are the most common. So one is this word finding difficulty or like tip of the tongue, phenomena where, I know what I want to say. It's on the tip of my tongue and I just can't, I can't label it. I can't get the name out or the object out. So people describe that as word finding difficulty. And sometimes when you start a cognitive focused history, you'll hear something like memory complaints or word finding, but you have to kind of dig into it a bit. So sometimes memory actually means word finding difficulty. Sometimes word finding difficulty means short-term memory. So anyway, this is where you start to think about the brain in different cognitive domains, which we can talk a little bit more about. But your history can be a bit kind of like domain focused where you have in mind that you're going to try to get at executive function. But the way you would ask it is not saying, do you have executive function problems, but are you having difficulty with thinking through or executing the sequence of the sequences in a task or problem solving, things like that. So you take the lead on the chief complaint and you start to dissect it, which I think is a general rubric for how we try to operate in the clinic, I'd say.
Yeah, that makes sense. And I think one of the most frustrating situations, and I'm sure that our primary care colleagues run into this even more, is that a lot of that takes a lot of time. So if you had to, let's say, prioritize what pieces of that problem to dissect, let's say, in, God forbid, 15-minute visit, what kind of things would be the biggest red flags that I need to definitely have this on my, have like something a little bit more than just, maybe, quote unquote, senile problems, to use an archaic term.
Yeah. So, I mean, I think if you think about, let's say, we'll give it like 4 different domains of cognition. So let's say attention is one. So as an interviewer, if you have in mind, focus and attention, you can ask, Are you having difficulty, keeping focus or sustaining your focus? So then in your mind, you're kind of working through these domains. And that would be one kind of domain in a cognitive clinic. I mentioned memory. So you can ask questions like, again, you're thinking of the memory domain. You can ask questions like, are you having difficulty retaining information from conversations in the short term? So people might describe this as short-term memory problems. So I might ask something like, I'll give an example quickly in this interview. In this interview format I'm describing, where you might say you're talking with your spouse tomorrow at, you decide that there's something you're going to do tomorrow at 1:00. You're going to go have lunch, with the Jones family. So that's all pieces of new information. So you can ask in a patient or family, you give them that scenario. So in your conversation with a loved one, are you holding on to information that you get that's new in the short term? That would be a way to ask about short-term memory difficulties. If we go on to executive function, like I was mentioning before, you might ask questions like, around the house, using appliances or doing small repairs or something. Are you noticing some difficulty with doing the kinds of things you did 6 months ago or a year ago? So the key is that you're focused. You have limited time. You have 3 or 4 domains: executive function, memory, attention. Let's say that's probably good. If you get something about visual spatial or spatial kind of orientation from difficulties from this conversation, you might ask about that. That's another of the kind of key brain domains. But that might be something like, do you notice that it's hard to differentiate like the background from the foreground in the room that you go into? Or when you find yourself sitting in the car, either as a passenger or a driver, and thinking about where you're going, do you have difficulty knowing how you're going to do it? So basically what we call like topographical orientation. So I'm going to take a left on Main Street and go by the grocery store, et cetera. So that's a way to kind of key into that kind of domain.
No, that's excellent. It's something you kind of mentioned that I always find, I'm just curious your opinion. How often, like when someone's like coming in with that chief complaint of the tip of the tongue word finding or the short-term memory kind of issue, whether that is the patient themselves versus is it a concern of, let's say, their spouse or one of their adult children? Does one of those elevate your suspicion higher than the other?
That's a great question. I would say no. I'd say you have to weigh the informant, the collateral, and the person equally. The script I have in mind is when I try to open up the interview and make it easy for people to kind of talk about these things, which is not always easy when you're in the room with a family member or friend or someone. I try to say, I'm not hanging my hat on any one piece of information here or any report. I'm just collecting information as an observer to try to get it out. And the reason why you kind of have to weigh those things equally in my mind is that there's, as people know, there's some degree of unawareness or anosognosia that's particularly common, even, or you can see the tip of it in even early neurodegenerative dementia that you might be screening for. You kind of have to, there's that. There's also the fact that, some people are more naturally self-reflective and in tune with their own mental functioning and cognitive functioning, and some people are not. It's like emotional literacy too, or emotional self-labeling and stuff where, psychiatrists have to kind of manage this, I think, as well. I listen to everyone. I see if there's congruence between the two. I think you can get a sense pretty quickly if there's a really concerned loved one who says, look, I've noticed 2 or 3 years of progressive short-term memory difficulty. And then I might then ask the patient gently, have you noticed some changes in your thinking or memory? And if the person says, not really, I'm fine, then you already kind of see incongruence between what the family member is saying. By the way, in a setting like that, what you can then say is something like, well, as we all get older, this is, for better or for worse, you're not going to want to hear this, but we all are a little bit less sharp than we used to be when we're younger. Have you noticed changes with normal, what we might describe as normal aging when you think about yourself compared to your friends? And then you can get people to open up a bit and acknowledge that maybe they've had some changes along those lines. So you kind of have to be open about it in a way.
Hypophosphatemia is often underrecognized, but the downstream consequences, such as osteomalacia, fractures, and functional decline, can be substantial. To our listeners, the single most important actionable message today is to check aphosphate. It's not on the typical chem panel, so you have to order it when the story fits.
Yeah, I actually wanted to follow up on that. I had the same question about who to ask the history to. But the other thing that I've actually seen some patients in my practice say is almost kind of excusing the symptoms. Like, for example, saying, "Oh, I've never been a guy like someone who could know my way around a city anyway. Like, I was always lost even without the GPS, let alone now." So kind of saying like I would have never been, high performing in that domain. Versus the other sense, I also have patients who, for example, I have an artist who was just like, no one else would know, but I am not the same, and so kind of in their own domain, having been a high performer in the past, noticing a decrement. So I'm curious how you account, whether you take that into account, kind of low, high performing self-report or by prior career experience, and just how do we account for that? And do we account for that in that initial history?
Yeah, that's a great point. And there's a lot of different kind of variability there where you have this kind of self-awareness, but you would never observe it, et cetera, like you described. So the framework that I often use for that is what's helpful for me in learning about this history. This is what I would say to patients and families is comparing yourself to yourself. So like when we think about you now compared to say, and I always say this is a hard question, but say compared to 6 months or a year ago, or you can ask this to the loved one as well, do you see this person as different in how they are functioning? So this gets out of the kind of targeted questions, especially related to daily functioning, where you might say like, are you driving now? Are you doing personal finances now? If you start like that and you start to go through instrumental activities of daily living to try to kind of tease it out, you get quickly in the weeds of, like you said, Galina, I've never done finances. I've never used the microwave. I've never done this. And then you're kind of a little bit lost in the specifics. Whereas if you open it up from the beginning and sort of say, when you think about your husband or your wife or your mother, and if I were to videotape their life a year ago and videotape a day in their life now, what changes in daily functioning and mental activity, mental acuity, or, wouldn't use those terms always, do you see our differences? And that that allows us to be like patient centered actually, and really get at what, changes for that person. You made me also think about this is hard to do, tease this apart. And this is where you start to combine obtaining clinical data and then integrating it into the history that you're getting. If I have a mixed view about what changes have actually happened cognitively with this person because the history is incongruent between the loved one and the person. And again, I think this can happen pretty quickly. I don't think this is that, doesn't have to be, to Michael's point, doesn't have to be that in depth of a, 1 hour interview kind of thing. It can be within 10, 15 minutes. This is when you start to integrate the kind of data that you get on basic cognitive screening tests, which we can get into. And sometimes the things start to declare themselves and the truth comes out a little bit if you see someone that's really impaired on a cognitive screener, whether or not they have awareness into the impairment or not. Does that make sense? You're sort of like starting to dig into like the out of the subjective, quote unquote, and a little bit into the objective data gathering situation.
No, that's a great point, and I think a great approach. I would be remiss as we go forward here, things that act like dementia but are not dementia or cognitive decline that I think we all see quite a lot of in that assessment process. Again, to borrow another archaic phrase, sometimes think of them almost as like the worried well. How do you sort out these things when you're kind of going through, like, as you said, the more subjective side of things? Are there any specific symptoms or habits that would point you more towards maybe again, I know it's not the current vogue, a pseudo dementia, if you will.
Yeah. So, I mean, one big principle comes to mind when I hear this, which is that it is more common to have multiple factors, medical, psychological, et cetera, to be the cause of cognitive impairment than it is to try to whittle down a differential diagnosis to get at, one disease. So it's not that you're not thinking that way as a provider, right? You are, you're wondering when you see even the chief complaint, you start to try to figure out, is this a progressive problem that is declining over time? So therefore I'm in the neurodegenerative kind of framework of thinking about the disease, or is this something that there was a particular triggered event like an ICU stay or something in which the cognition, kind of started to be impaired. But when you're thinking about that and you start to ask about psychiatric history and current psychiatric symptoms and current medications that someone is taking, these are the other causes for cognitive impairment, right, in this age group. What I'm trying to get at here is that it is okay to not be sure whether someone's, pre-cognitive impairment depression is still playing a role in their current cognitive performance, for example, right? I mean, we do have the goal to try to make, say, a neurological diagnosis, and that's fine, but I just want to sensitize to the idea that it's often multifactorial. And so, like, a great example of that is, you have a patient who comes in, they're in their 70s, they have, say, 1 year or 1 to 2 years of cognitive concerns. The pace is not clear exactly. It's not clearly progressive, but you wonder about it. And people, let's say the spouse is a little bit more concerned and observes more than the patient sees. And then you get a screening lab test, battery of tests like thyroid, like TSH and B12, folic acid, say vitamin D or something. And the TSH is off. So a kind of Occam's razor thought there is like, well, this must be the thyroid that's the problem because, there's really high TSH, et cetera. And I'm just guarding against closing off at that point and saying, oh, well, then this cognitive impairment of this older person is clearly hypothyroidism, right? That's all. Because it is really common to have multiple things. That person might also be taking anticholinergic or, medication as well. But I mean, the traditional divide between this dementia and pseudodementia is this idea of like, and this is not, as accurate as the words would imply, but there's kind of reversible and irreversible dementias or dementia and pseudodementia. And it is worth, and people probably know and remember that in this like formally kind of reversible category are things like metabolic disturbances like thyroid and vitamin B12 deficiency, polypharmacy, severe depression, things along those lines. But anyway, so it is worth it, but just keeping your mind open is important as well. One thing I'll add there is that it's helpful, I think, hopefully for all providers to hear that if you have in mind in the neurodegenerative space that you're seeing someone, you're assessing them for the first time. If you think about the 3 or 4 major neurodegenerative diseases, and it's worth talking about. So say, Alzheimer's disease, Lewy body dementia, and say frontotemporal dementia. So I'm not putting vascular dementia in that category because let's say for argument's sake, it's not neurodegenerative, even though you can have degenerative changes, but let's assume that it's a little bit more static for the argument that I'm making. It's really helpful to know the basic symptoms and syndromes that you see with those like 3 diseases. That will go a long way. Alzheimer's disease, even though it has different presentations, cognitive type of presentations, the most common is like a slowly progressive memory predominant decline for people in older age. For example, just that basic idea will help you because if you start to take a history and it's just not clear it's progressive and it just doesn't seem to be memory predominant, it decreases your diagnostic confidence or certainty that you should really like evaluate that further. I'm just thinking of the kind of way that you would approach a patient in which they're older and they have cognitive complaints. And it's like, where do you really start with it, right? Similarly, let's take something like Lewy body. If you have the basic symptoms in mind and the basic cognitive profile, So I'll tell you, so it's someone that has dream enactment and or nocturnal vocalizations that could have started a while ago. It's important to ask about that. Sometimes it's 10, 15 years before. There's interesting data on that and predicting someone developing one of the alpha-synuclein diseases like Lewy body, and you hear that or you ask about sleep and you get that history. You're then starting to think about things like, you know, mild Parkinsonism with an early patient. So you might have some rigidity and things like that. Then you might ask, do you see things that other people don't see, or do you have some, changes with your vision or visual misperceptions? You can say something doesn't look like it should be. Then you're sort of building a little bit of a pattern to do a focus interview. My point to zoom out is just that you don't have to go in blindly if you have the couple of symptoms for the major 3 or 4 conditions that you're going to see commonly, and that can help you kind of whittle things down. I think I diverged into a couple of different topics there, but that's my long answer to the question about like kind of what do you do when you start this interview and you're just not sure. It's pace, it's pattern, and it's kind of what are the other factors that could be reversible that are part of the picture. Those are all important.
Seth, I really like that summary and that framework. Can you wrap up with the third one for us, for those listening? So for frontotemporal, what would the
Yeah.
hallmark signs be?
So the typical kind of syndrome, we would say, so what you see in the patient, the behavior is, there's a couple different variants. There's the behavioral variant of frontotemporal dementia, or a couple phenotypes, I should say, in which someone often has changes of social cognition. So like their decorum, seems, off. There can be behavioral disinhibition. So their filter is a little bit less filtered. They might be, and you can see the tip of the iceberg of this. They might be just a little bit inappropriate, a little bit socially inappropriate, for example. You can also see changes of dietary patterns. It can be the classic description for this is a sweet tooth. So you can ask about whether have there been changes. The example I usually ask is something like, this person never liked, um, Chinese food until last week, and now they have to have it all the time, in the last couple of weeks. So it's not just this classic sweet tooth example, but it's adoption of a kind of restricted behavior that's out of the ordinary, inappropriate. Those are kind of obvious things that you can see with the beginnings of frontotemporal dementia. And then the other common, just for simplicity's sake, of that condition is in the language domain. And those people might be familiar with hearing like the primary progressive aphasias or the language predominant. And there you can ask questions like, has there been a change in language output or speech output for this person? Do you notice word substitutions? Do you notice output problems where it sounds like a Broca's aphasia sometimes, so the way that you'd ask a patient, a family is the speech halting and it feels like it's hard for them to get out the sounds and the words. Again, those are the typical examples of the primary progressive aphasias and the behavioral variant front. But you kind of sometimes see the tip of the iceberg for that when you're doing initial assessments. So again, if you have in mind, back to my previous point, hey, this is a person where I'm getting a flavor that it's not cognition alone, right? Meaning it's not executive function or attention or memory, but actually I'm getting a flavor of some behavior or some language. I'm going to dig into that. I'm not going to let a passing observation of, it seems like dad his filter's a little bit off. I'm going to dig into that a little bit and ask, give me the examples, what situation, and then I might ask about restricted behaviors and things like that. So you just let what the report is guide you and dig in a little bit more to it. I think I did justice to that final disease, hopefully, Galina.
Yeah, you did. That's so helpful to hear your approach. What I've loved about these series is that we have this kind of pattern, the first higher level point is like, don't, trust but verify the history, like the words that patients may use may differ. And then the second is that you have this almost, I heard someone say something called like the accordion of the neurological history or the exam, where you can kind of open it up and close it in. And, you're not really going in with those guided questions or leading questions, but if you hear and pick up on something in your mind, you're categorizing it and then pursuing it further. So that's really helpful. I also appreciated, Seth, your description of some of the, quote unquote, whether it's the right term or not, reversible or irreversible factors. And I tried to think about that as well. And I'm jumping a little to management, but in my mind, I often ask about the things I potentially could have an impact on. So I'll ask about sleep or substance use, for example, when I'm doing my history, and then kind
Yeah.
of circle back. So can you talk to us about those two elements? And is there anything else that you're asking about when you kind of think about those reversible elements?
So I think that mood is one important place to start there. So, concurrent with complaints of cognitive decline over time is often changes of mood. And I tell people that that is normal. I mean, whether or not you have reversible or irreversible, quote unquote, cognitive difficulties, that, it itself can be the cause or the trigger of being down or anxious or, frustrated about the cognitive complaints. So I'll dig into that in interview and try to get that out a little bit more. I mean, I will ask about basic questions, getting pleasure out of activities, the kinds of things that you would ask to screen for major depression. I think you can ask in this population as well. Um, are you getting joy out of some of the activities that you do? Do you feel down some of the time, a lot of the time? As opposed to, are you down? Are you depressed? You can kind of give them an out and an easy way to start to talk about it. So I think digging into mood, and I'll put into mood also, so mood, we think about depression and mood changes, but, like things like anxiety. So using terms like, more nervous than you used to be? Is it different do you feel more anxious during this time in which you or your loved one has also noticed cognitive difficulties? Is a way to kind of dig into that more. Looking at medications and med reconciliation is really important for cognitive uh, side effects of medications. I mentioned anticholinergic medications before. I mean, there's a couple of kind of, key culprits that are pretty anticholinergic medications. I'll throw oxybutynin in under the bus, because for neurologists listening or primary care, other providers, this is like, I've seen, examples of sort of like this medication causing like significant cognitive difficulties. So I'll do like a general medication review, of course, but also I think another thing in this realm of questioning is, when did this all start, so to speak, right? It's not uncommon for there to be an unmasking of a dementia process, of a neurodegenerative process, in something that we want to in an event that we want to attribute as the cause, or family members will often say, it all started at this time. But it's not that the ICU stay or, the urinary tract infection is now the cause of what seems to be an emerging Alzheimer's disease. It's just that the brain has only so much reserve. And when you sort of like, have a metabolic derangement like UTI, or someone has a concussion, like or basic head impact without a lot of post-concussive sequelae, but you just, you find out that, dad hasn't been the same since like the car door came and, the trunk came and slammed on his head. It's easy to attribute and say, oh, well, then it must be because his cognitive difficulties are because the cognitive. And I've had many, many cases where if you ask about the history prior to the event in which the family is attributing as the beginning, you get some subtle changes. So the questions I will often ask in that situation is, let's go back to before the ICU stay. Even if it was subtle, did you notice that things were a little bit different with short-term memory and word finding, or with, and you may get a positive or negative there. But all that to say is that, like everything in medicine, you're looking at what you see now and what happened before, and then you're trying to figure out what this is going to be in the future, if that makes sense to people. So it's really important to kind of pinpoint the beginning part of that. Sleep is also important for a number of reasons. A common question I'll get in the clinic these days, because there's a lot of headlines and public discussion about, chronic poor sleep and increased risk of dementia, which is true, in that we know from epi studies and population-based studies that the risk is for chronic suboptimal poor sleep, that there's higher risk. But practically speaking, with an N equals 1 patient sitting in front of you, it's difficult to sort of say, this person is chronic, to say to a patient or family, well, you've had chronic sleep for 20 years, and this is the reason why you have like early Alzheimer's disease, right? This is a really challenging thing to navigate when you're trying to figure out what's going on with someone. So, practically speaking, related to sleep, I think if you ask about current sleep, you get a brief history of sleep in their adult life briefly, and then recently, you can start to gear things towards treatment, first understanding what it is and then thinking about it. One thing with sleep that comes to mind is that neurodegenerative diseases, like the ones we've talked about, have sleep fragmentation and sleep difficulty as part of the process, as part of the syndrome that you see with the pathophysiology. Someone, again, to the point about the worsening of prior problems, someone can have intermittent, insomnia or poor sleep, and then it kind of all unravels and gets worse when Alzheimer's disease starts, for example. So, you can also have new onset sleep difficulty and memory difficulty, let's say, as the first presentations of something like Alzheimer's disease. Um, so it's a mixed bag, but those are the main things that I think about. You mentioned, I think, Galena, substance abuse too, or substance use. This is a really common, at least in my cognitive clinic, which is it's often, so say it's, frequent alcohol use, or I've seen a lot of cannabis use, for example, in this older population for different reasons. I would say that most of the time I'm I'm thinking about, when I hear history of current alcohol abuse or alcohol intake, as well as cannabis, I'm thinking more of what contribution is this causing to the person's cognitive difficulties, especially if I'm concerned about like an early neurodegenerative dementia, rather than attributing the cognitive difficulties to the cannabis use or alcohol use, right? So people may know, or should, probably remember that there is a kind of dementia with severe chronic alcohol use that is, called alcohol dementia or alcohol related cognitive impairment, in which you have confabulation and some of these dramatic cases that the providers may remember from learning about in medical school. But it's really exceedingly uncommon, at least in my practice, to have to just attribute, you really like kind of chronic alcohol use to what we would call alcoholic dementia. And there really isn't like any biological marker for that. Of course, there's MRI findings that you can find and attribute. So practically speaking, we do know, and the pendulum has swung in the direction people may know, sort of like advising against less and less alcohol intake than we did a couple of years ago. Even practically speaking, reducing substance use for things like cannabis and alcohol that can really impact cognition is a great way to start to tease apart contributions to their cognitive complaints. I usually tell someone who has current alcohol intake to start, during this evaluation process, to start by trying to cut alcohol in half, for example, to sort of see what's going on. Yeah, so it's messy, like everything we do, but this attribution issue of having in your mind and kind of figuring out what is at play here, and having a little bit of a rubric to dig into those different factors will help you assess, what is the contribution here. We, well, go ahead, Michael.
Oh, so, I know a lot of what we've been talking about is kind of, a lot of the examination of these kinds of people is talking and asking questions. Is there anything in the physical exam itself that you would say is not necessarily typical as part of someone's usual screening neurologic assessment?
That's a great question. I think that, for example, what comes to mind is we didn't mention vascular cognitive impairment or vascular dementia. So this is maybe the second most common reason for older age, dementia, cognitive impairment. And one thing that I do in the clinic, neurologic exam wise, is on motor exam, for example, I'll look for some laterality in weakness, or findings that would suggest, some kind of motor dysfunction. Because if I haven't, and, if I combine that with a patient who has a history of systemic vascular disease like hypertension or hypercholesterolemia and things like that, I'm building a little bit of a picture of, well, maybe they have subcortical ischemic vascular disease, maybe they have some lacunar infarcts, maybe they haven't been imaged before. So that's one thing. So laterality on motor exam. For patients who, after, say, a cognitive screening test like a Montreal cognitive assessment that's clearly abnormal, or something along those lines, people that have some saccadic breakdown on motor exam, on eye movement exam, can be a part of the picture. Again, as you said, it's not pathognomonic for dementias, but you often see some saccadic breakdown in patients who are further along in impairment with dementia. Gosh, I mean, I think our best tools in the cognitive clinic, I actually think about it in three ways. I think there's three helpful pieces of information. Hopefully this is helpful for PCPs to kind of think about too, which is the symptoms, which is like the syndromes, the pace, the specific domains we talked about, the behavior, the affect, just basically the symptoms, imaging, so neuroimaging of the brain. So MRI is typically, better if possible to get than CT of the scan. And then cognitive and functional performance. So cognitive testing, memory testing. And that can be in a primary care office, that can be a screening test like the Montreal Cognitive Assessment. The Addenbrooke Cognitive Assessment is a good one. The ACE, it's a little bit more comprehensive than the MMSE, than the Mini Mental Status Exam. I encourage people to check it out. The ACE is just one that comes to mind. There's the Addenbrooke Cognitive Examination Revised, or R. I think that's in the public domain. You can find that. So I think about those three pieces of streams of data that help you narrow what can be a really wide differential diagnosis. So that begs a number of questions like, I see someone, the pace is slowly progressive memory decline. I'm not sure, but I'm concerned about a neurodegenerative disease. Could be Alzheimer's. I do a MoCA test. The MoCA is, 22, 23 out of 30. Do I get brain imaging for a patient like this? And I think that increasingly, I'd say that the answer to that should be yes, right? In at the primary care level. And I know we were chatting a little bit before about how hard it is, in having a short amount of time, in seeing a patient like this in a primary care office or in a general neurology clinic or geriatrician's office or anywhere. What do I do? Like, what do I actually obtain for this patient? I think if you think about these three streams of information and you've done a little bit in each, which has helped to, including a brain MRI scan, which, just to talk about briefly, you can see on MRI scan if there's significant changes in the white matter. So, people might be familiar with like white matter disease, microvascular disease in the brain, what you can call subcortical ischemic vascular disease. You can see strategic strokes where someone had, a silent stroke in the cortex that is part of of frontal dysfunction. Let's say it's a frontal stroke or something along those lines, etc. And you can also see, and this is the more tricky and nuanced part, but it's helpful to get as you're, say, maybe waiting for someone to get to a neurologist's office, you can see a pattern of volume loss or atrophy that in the right setting is suggestive of neurodegeneration. So what I mean by that is if you have a one-time scan of someone in their 60s or 70s MRI and you see a little bit of, say, volume loss in the hippocampus or the medial temporal lobe, which is a common place that you start to see atrophy as diseases go on, by itself, you can't say that, this is supportive, or I should say that this is, clearly a neurodegenerative disease like Alzheimer's. But in the right context, you can say that combined with the history, it's like everything that we do in medicine, right? Putting all the pieces together, combined with history, combined with symptoms, which is history, combined with neurocognitive testing and MRI scan, you can kind of start to build the picture. So I don't know hopefully that starts to get at this question.
So I did want to add in one thing, or I should say ask. So I know you mentioned several cognitive assessment tools. The one that I probably see the most that has been done in PCP's office when they get referred to me is the mini-cog. I know obviously it is probably the most brief out of all of these. Does it have value as far as let's say as a screening tool?
I think it does. I think it does. And again, I think it's easy to learn and easy to administer, and the other tests take longer. And I do think that an abnormal mini cog combined with a good 10-minute history that teases apart kind of the stuff that we talked about, and maybe something concerning on MRI is a really good value add for going towards a diagnosis. I do think so. You know, on the other side of things, which is that if you, let's say, are in primary care and you see someone back where you're building these tests, you have some evaluation done, and you've already done a test like the MoCA and it's borderline. One really helpful cognitive test to throw in is that you can do really easily and learn easily, which can kind of help your differential diagnosis towards something like Alzheimer's, for example, is a verbal fluency test. So you can ask someone to do two things. You give them a letter of the alphabet, like F or S, and you take your watch or phone out and you time them for 1 minute, and you have them generate as many words as you can that you say, tell me as many words as you can that start with that letter. It's called phonemic verbal fluency. And you just write down, you count how many words that they generated. And then you do the same thing with a category. So you say, you give them either animals or vegetables or something like that. And you say, I'm going to give you a minute. I want you to list as many as you can. A really helpful clinical pearl with the results of that test is if they have worse category fluency. So they name less category items than items that are generated from one letter, or the phonemic fluency. And especially say if it's a significant gap between those two. So say it's 17 S words, but 5 or 6 category words in vegetables, combined with an abnormal MoCA test or even an abnormal mini-cog and a history suggesting progressive cognitive difficulties, in particular something that's memory focused, which is the most common, then that's really helpful for Alzheimer's, for like kind of having a diagnostic confidence that Alzheimer's disease is higher. So that's a verbal fluency test. Another test that just comes to mind that I really like is there's a couple different to think of, but one that's easy to do is the trail making test, part B and part A, that people might be familiar with. It takes a little more time to explain, but essentially you're having them track on a sheet of paper, and you can find the stimuli online if you search for trail making test part A and B. You can use each of them respectively to get a sense of processing speed and working memory in one case, and the other is more of kind of the part B is more of kind of executive function and like what we call set shifting. So you would do a test like that if you noticed, and I think the big picture here is if you see the divisions of the MoCA are divided into things like memory and abstraction and attention, if you see real impairments in one of those and you want to tease it apart a little bit more, in particular for, say, attention or processing speed or thinking, these are tests that you can do pretty easily to kind of corroborate that or challenge that.
Now, I would be remiss if I didn't ask. We talked a little bit about MRI brain as part of our diagnostic imaging, but there's been a lot more emphasis in recent years on like different biomarker testing, both via like lumbar puncture, spinal fluid testing, as well as like these, PET tracer scans. And I think just in the last few weeks, there was clearance for a serum marker for Alzheimer's. So what's your perspective on these? Should we, because I am in my gut, I am sure that we're all going to be seeing a lot more referrals for patients who are going to be having some of these positive tests, and the symptoms may or may not correspond, right? It's always that, imaging clinical divide there. What role do they have in your practice, and what role do you think they should have in a primary care practice?
Those are great questions, and they're active area of clinical research, of course, and everything. They're really here and used and present, and they're everywhere in our clinic. So just starting with like the two gold standards for assessing Alzheimer's disease pathology that we've been using in the clinic, in the cognitive clinic, actually, as people probably know, for 10 plus years, starting with that one first, is spinal fluid testing. So spinal fluid testing with a pattern of beta amyloid and tau protein in the fluid in a particular pattern is really helpful. So this is really like a confirmatory biomarker. So when would you use a test like this? So there are actually appropriate use criteria published for spinal fluid testing for amyloid for Alzheimer's disease. But in brief, if there are cases where the history and the age and the domains affected, so say not memory, not clearly someone in their, say, late 60s to late 70s, and I guess those are the kind of main things, and you want a confirmatory biomarker, like a test like spinal fluid Alzheimer's biomarkers that is going to be like a tiebreaker or sort of like a helpful decision maker to confirm the disease, then that's the setting that you would use a test like that. And whereas in a typical, I'm going to say a typical case where you have slow progressive memory decline with abnormal cognitive testing, and let's say even an MRI that has like a pattern of some tissue loss in the temporal lobe and parietal lobes. I just described, by the way, like a typical Alzheimer's disease patient. You really don't need to do a amyloid confirmatory biomarker either by spinal fluid or by PET scan. Now, having said that, since the two new drugs for Alzheimer's disease have been out in the last year and a half plus, which are monoclonal antibodies, anti-amyloid antibodies, lecanemab and donanemab, the whole paradigm of doing biomarkers has shifted. And I know, Galina, you mentioned at the top of this hour that, gosh, there's a kind of urgency now in neurology clinics when you see a patient who could have specifically early Alzheimer's disease to get the necessary testing and diagnostic confidence that they have Alzheimer's to get them to treatment. This is a total kind of paradigm shift in our use of these biomarkers. And in the last year and a half as well, we started to use amyloid PET. So that's tracer for beta amyloid in a PET scan in the clinic more commonly, overwhelmingly more commonly, because it's less invasive than doing spinal fluid testing, and it gives equivalent information actually to what you can get in spinal fluid. We've been doing those to evaluate patients to confirm early Alzheimer's disease. Now, just almost ready for prime time, but I don't think at the recording of this podcast we're fully ready to use blood biomarkers yet, even despite the FDA green light for the LumiPulse test that Michael was getting at. The story with blood-based biomarkers is that amyloid in the brain is just challenging broadly because people with normal, with normal aging or people that get in their 70s and 80s can have a level of amyloid in the brain in which they would have a positive amyloid PET scan, but at a low level. Those folks, and there's debate about this given the current consensus criteria, but those folks who don't have any symptoms, let's say, but have a positive biomarker test, are not eligible for treatment with one of the two new medications. So they've been described as having preclinical or asymptomatic Alzheimer's disease. Okay. And this is a really interesting topic for maybe like a whole nother podcast to do, but those patients are, by the 2024 criteria of Alzheimer's disease, by the Alzheimer's Association criteria, are technically have stage 1 of Alzheimer's disease. So stage 1 is biomarker positive, no symptoms. Now, there's things to unpack there for sure, but thinking about blood testing, blood marker testing of these fragments that are shed in the brain, phosphorylated tau and beta amyloid 42, for example, or beta amyloid proteins, that kind of testing is good to corroborate these days in the gold standard amyloid PET scan or a spinal fluid testing. So I don't think we're ready, even in the specialty office in my clinic, to use those alone to confirm a diagnosis of the disease. We're almost there, but we need a little bit more real world evidence given just the huge variability of what you see in patients and how to interpret the levels of those testing. So that's a long answer to a very short question, but I think it's going to be some time before the blood test can be used in primary care as a screening test, although we may get there. And even still, I think the current gold standard in the right situations is to do an amyloid PET or spinal fluid amyloid testing, to try to sum it up a bit.
No, that was excellent answer to a definitely controversial topic in a lot of quarters. So thank you very much. And I know even in my own practice where I have to refer folks for the amyloid PETs, and if they do want to get any of the anti-amyloid therapies, just because we're not set up for it locally, so I always have to refer them to one of our local academic centers. But kind of moving back to the primary care or even the general neurology side of things, right? There's all these medications that have been around for ages. What role do they have? Thinking of things like donepezil, Romantine, or some of the other medications, kind of in a similar vein. Do they have a large role to play, and what kind of expectation should we have for their performance in practice?
That's a great question. I think they do have a role, and even though the studies that led to their approval and why they've been used or studies that led to their approval were, had modest benefits over 6 months or a year, et cetera. There are responders to these medications. There are people who have a clear, observable boost in cognition. Maybe it's 30% or 40% of patients, just anecdotally, like is the number I have in mind in my clinic, where for short periods of time, 6 months or a year, families and patients observe some boost in these medications. They are, I think, really important to consider still and to use. So there's different reasons for that. One is that the majority of patients that we all will see in clinic, not majority, but let's say like close to a majority, may be past the point of being eligible for getting the new anti-amyloid therapies. And so we have to be aware that I think everyone deserves a trial of pharmacologic intervention for Alzheimer's disease. This is my view, and I think the view of a lot of like cognitive subspecialists. Um, and that's because people can respond, and they do respond. And so I think we should keep these in mind. A common thing that I see is that I think it's important to note that most care of cognitive impairment and dementia patients, just numbers wise, statistically, is done in internal medicine and in primary care, if we think about the distribution of care in this country. And so many PCPs and family practice folks and geriatricians are actually using donepezil and rivastigmine and galantamine and have experience with it and have used them. One common thing that I see is, say a patient with a presumed Alzheimer's diagnosis is being treated with donepezil, which is Aricept, for example, and it's on for some period of time, maybe a year or two, and then the conclusion is it doesn't work. It's not working. And so it forces us to examine like what was the goal of that medication, which gets at your expectations question, Michael. What do we expect in these medications? So I think the general experience is that some people can observe that there's improvement. Some people, smaller amount, can't tolerate them. Do the cholinesterase inhibitors do have some GI side effects? We have to be aware of that. But I think knowing that there's modest expectations, and that as long as there's no kind of contraindications in the patient's other medications for taking those meds, it does make sense to keep them on board as long as it's reasonable for longer than 6 months or a year and a half. I mean, I typically will keep them on board until there's a good argument to get rid of them. Now, part of that is because there are some studies and anecdotal experiences that when you get rid of medications like Aricept and Memantine, you sometimes do see worse cognitive performance and at least definitely a rocky period. And again, if there isn't a compelling reason to stop them, like polypharmacy, and sometimes there is compelling reasons to stop the medication. I typically keep them on board because I do think they're boosting the brain. I mean, they're providing acetylcholine in the case of acetylcholinesterase inhibitors, and they're having some benefit on excitotoxicity with memantine in the brain. I'm of the camp where they should be maintained for the foreseeable future for most patients, for these types of patients. Maybe I'm an outlier there, but I think it's important to get that voice out there. There is a bit of a nihilism with them. I appreciate that, but those medications were never studied or presumed to be curative medications, of course, or even reversal medications. And so if we can give people a boost for diseases like this, I think we should do that in any way.
That makes a lot of sense, Seth. And I like that you mentioned that often that is being trialed at that, primary care stage, like if it can be offered, especially while someone's waiting or just to give it a go. And I'm wondering if you could just touch on in the last minute on anything else that you think our primary care providers can counsel on. As you mentioned, they're kind of seeing the burden of these patients and probably also doing the burden of the education around lifestyle changes and prevention. And that's really their, that's their expertise, our primary care physicians. So what are your kind of, Seth Gale stamped lifestyle changes that they should be counseling patients about?
That is a great question, a great way to end. So I think what I would add it to this, to the kind of patient population we're talking about, is there is this idea of subjective cognitive complaints. Okay. So these are people in which they often have a family history of dementia, not always, but they could. They have some subjective complaints of memory and thinking difficulties, and they come and they are concerned, of course, like anyone would be, about developing dementia. So for those patients who we put in this like kind of subjective cognitive complaints category, because if you do general cognitive screening for them, like a MoCA test or even detailed neuropsych evaluation, they're often normal. They have normal results. They're a great population to advise on brain healthy behaviors. Now, everyone who is 30 and above should be doing brain healthy behaviors. And I often will say that to patients that, here's the kinds of things to do. And so those include, aerobic exercise. So that's like really recommendation 1, 2, and 3 is the way I think about it, based on what we have from all the epi and population-based studies. And again, practically speaking, to help patients, it's baby steps here. You have people who are a little bit active, but not very active, but their heart rate hasn't gone up a lot. You don't want to tell them that they have to do 150 minutes a week of light to moderate aerobic exercises, which is what the World Health Organization advises, because they're not going to do it. Even with a good relationship with you, they're gonna come back in 6 months. So this is like any human behavior change, right? You lay out the counseling that, hey, it's really important to exercise. And here's why. We have good evidence of reduced risk of dementia, et cetera. And then you say, let's walk a quarter mile around the high school track near your house, every day for the next 5 weeks. Or not every day, 3 times a week for the next 5 weeks. You know what I mean? So it's incrementalism, right? You're inching people forward on behavior change. There's that. There's healthy eating and diet is important in these studies for reducing cognitive decline in dementia. Typically the Mediterranean style diet and the variation of that people might have heard of called the MIND diet, which is a variation, that's MIND, like brain, mind. It's a variation of the dietary approach to stop hypertension, or the DASH diet and the Mediterranean diet are important. And again, this is a marathon here. So, people, have developed their diet habits. They're in their 60s, 70s, but you can give them a food pyramid of the Mediterranean diet. Most people have seen it. Doctors like to talk about diet and exercise, right? This is not rocket science, but it's really important. You can really budge the risk of. So to emphasize that point, these things I'm mentioning are really important. Of course, they're good for the heart. They're good for the brain as well. And I guess the third bucket in this is this kind of keeping the brain active bucket, the social and mental stimulation category. And a common question there is, well, talk with my nephews and family members on the phone a couple times a week, but I don't play card games or watch History Channel programs. That's fine, right? Because there's no prospective study that has shown that crocheting, is better than doing cognitive tests on the computer. And I think this is a really important point, right? That the way that we know what I'm saying to be true from the large population studies is that you ask people over time, tell me about the mental and cognitive activities that you've participated in this month. And you do that for years and years in these long-term aging studies. And it's a lot of different things that people can do that seem to be part of the recipe for reducing dementia risk. It doesn't have to be a particular thing. And back to my behavior change point, if someone is inclined towards picking up or going to sit at the piano that they haven't played for years, but they used to play piano, when they're inclined to just do that for 5 or 10 minutes a day, it's much more likely they're going to sustain that for the next couple of years than if you give them something. I think that's a really important point with lifestyle. But those are kind of the 3 buckets. And I'd also tell people finally that there's some great resources on this and on brain health to check out. I'll just plug the Massachusetts Alzheimer's Disease Research Center, or MADRC. You can Google it. You can find it. There's some great handouts on that page for patients and families that are called the Roadmap series. Of course, that's what I go to in my mind because it's regional here, but that's something to check out.
I absolutely love that those buckets, the reminder of how important this is. I'm also a bit of an annoying stickler. I make everyone get hearing tests and check their eyes out. And I say, if you can't hear, you're definitely not going to remember what was told to you by your family.
Yeah.
But I feel like I've reversed a few dementias. I feel proud of those successes.
You should be. Those are in the modifiable risk categories. There is absolutely. You're doing the right thing.
Well, Seth, this has been so wonderful. I always learn something new when I talk with you, and it's just incredible to see you and your colleagues in the cognitive neurosciences just really take on this new wave of opportunity and enthusiasm that we all have for potentially having treatments for some of our neurodegenerative conditions. So thanks again for joining us and sharing your wisdom.
Yeah.
It's been a pleasure. Thanks for the conversation. It's been great.
I learned a lot too. Thank you, Dr. Seth Gale. Anything else that you want to plug other than the resources you've given us so far? Any projects that you would want people to check out or other resources?
One thing that comes to mind is for your patients that are interested, there is something called the Brain Health Registry to check out in this last category. And that's something to check out. This is like an online study for anyone age 18 and above to be involved with. You can register, and it's sort of we'll feed you some cognitive questions every couple of months. And it's a kind of a way for people, especially that want to be part of a registry and part of research, it's an easy online way to do things. But otherwise, I can't think of anything else. And I appreciate the conversation.
Likewise. Thank you so much. So thank you everyone again for listening to us. This was, I thought, a very edifying conversation. As always, if you liked what you heard today, share it with your friends, share it with people who work in medicine, and, leave us a rating and review. Only if it's 5 stars, though. You can find us on X at neuro_podcast, and you can always find our past work at our website, theneurotransmitters.com. Thank you, Dr. Gale and Dr. Geichman, as always. Take care.